Well, thanks everyone for coming today. And thank you for inviting me to speak. As you know, my name's Morgan Sauer, and the first thing I always tell people to do is when someone is going to get up and stand up and talk to you about something, the first thing you need to ask is, why does the person speaking have any right to speak to you? Why are you not the expert in this subject matter? Or what can this person teach you about this? And so listing credentials, I think, is always a little important. I was born and raised in Arkansas. I am the product of public education in Arkansas. I'm very proud of that. I graduated from UAMS, University of Arkansas for Medical Sciences, 4301 West Markham, where healthcare lives, and graduated there in 2000. And then I did a family medicine residency from 2000 to 2003 and a geriatric fellowship at the Don W. Reynolds Institute on Aging from 03 to 04. And while I was there, I got to work with the father of hospice for Arkansas, a great physician named Reed Thompson. As he said, he was a born-again ENT. He was an ENT, but he really got into palliative care and hospice care before pretty much anybody else in the state did, and really did a lot to promote it. With his training and with the support and the encouragement of David Lipschitz, I actually started working in hospice immediately when I came out of my fellowship, in addition to geriatric clinic. And I had the fantastic opportunity to work with Teresa Travis, who is also a physician. And I say, if Reed Thompson is the father of hospice in Arkansas, Teresa Travis is definitely the mother of hospice in Arkansas. And I worked under her training for years at hospice home care. And with her training, I was eligible to sit for the boards. And so I'm board certified first in family medicine, then in geriatric medicine, and then in hospice and palliative medicine. As my mother says, I have a habit of taking expensive tests, or a hobby at it, and I'm very good at it. So no more expensive tests for me. With this, hospice and palliative medicine is kind of one of the toddlers of the healthcare system. We're just being introduced. Cardiology has been around for a long time. Pulmonology has been around for a while. But palliative medicine and hospice care are really, in the spectrum of things, relatively toward its infancy. We are becoming much more needed. We've always been needed, but we haven't been there. But finally, there are people who are kind of listening to the message, and it's interesting, they're not listening to the message from the physicians, they're listening to the message from patients and families. And that's what's given us our birth. That's what's given us our place at the table, or our niche in the healthcare system. Patients and families have been asking for us. Quite frankly, the American healthcare system is in one of the largest states of flux and change that it has been in the past 40 years. And we're having a lot of changing of priorities and of how we're doing things. In the past, we just did everything in the hospital. We did not acknowledge death. People did not die in the American healthcare system. Well, according to the American healthcare system. We realized that we were not doing a good job at the end of life. And unfortunately, my grandparents were suffered under that. They suffered from getting terrible end-of-life care. It hurt them, it hurt my mother, it hurt my family, and it was during my childhood, and so it had a very unique impact on me. It probably pushed me subconsciously into this line of medicine, and I couldn't be more thankful for that. One of the things that is also happening is that we are becoming more of a patient-centric model. When you look at how healthcare is going to change over the next 2 to 3 years, everybody hold your horses. A lot of people do not understand this, including physicians, that things are changing. The way that physicians get paid is changing. We are not going to be paid on fee-for-service. Give out 2 burgers and get $4. We're about to be put on, we're getting report cards. Everyone's seen kids and had their report cards. Well, guess what? Physicians are about to get report cards too. And one of the measures on that is patient satisfaction. So if we take patients and we put them into the American healthcare system and we use all of our technology on them and do exactly what the patients tell us not to do, if we even talk to them about it, these patients and families are not going to be happy. And physicians and hospitals are going to be the ones who pay the price. That's why we have the healthcare team. And teamwork is really important. Physicians, mid-level providers, respiratory therapy, case management, social work, chaplains, volunteers. The whole team has got to be present and understand that the way that the healthcare system is changing. At Baptist Health Systems, it's our responsibility to teach our employees and our employed physicians and the physicians who practice in our hospitals what changes are coming, both so we can help take care of the physicians and their families, and we can help take care of the nurses and their families, and to take care of our hospital, to continue the tradition of excellence that Baptist has had for decades. We all want to do a good job. I mean, how many people go to work to say, wow, today I hope I really do a horrible job. Man, I want to do bad. Nobody does that. We all want to do well. We're all in healthcare for a reason. We have a giving nature. We want to help other people. And so we have to teach everybody how we can give to other people, how we can give to our patients, how we can give to our families, how we can improve their lives, and when their life is limited, because we cannot grant immortality here. And it scares me. What if we could grant immortality? Would we really want to stay in the conditions that we create? Not me, and not all of my practice when I was in geriatric practice. We don't want to be vegetables. We don't want to be laying in bed crapping all over ourselves. We don't want to be in bed urinating on ourselves. I do not want strangers putting their hands cleaning my genitals if I have gone to the bathroom for the last year of my life, like my grandparents had to suffer. That is not dignity. That is not acceptable to most patients and not acceptable to most families. So palliative medicine and hospice medicine have started to come along to help. What I say at this point, we're even rescuing people from the American healthcare system. We can go upstairs right now and I can show you techniques that are being used on people with our technology. And technology is not bad. It's how we use it. I mean, a screwdriver can be great. You know, if you pop open a can and someone goes and paints my living room so I don't have to do it, I consider that pretty fantastic. If someone puts a screwdriver in my tire and they pop my tire, I'm not going to be very happy. And so our technology is just a tool, but it's how we apply those tools as a team to precious, dignified, beautiful people. That's really important. And we can go upstairs and see where some of that technology is actually artificially prolonging the dying process. We are doing things to people in the American healthcare system that we cannot do to ISIS terrorists at Guantanamo Bay who are trying to destroy our entire way of life because it is considered torture and not allowed under the Geneva Convention. But we can do it to our loved ones, and we call it American healthcare, the best healthcare system on the planet. Isn't that a way of thinking about things we've never been taught? No one's ever said that before. So it's about looking at things in different ways. So this talk, I want to start helping people move forward, start thinking about different ways, and how to access other branches of the healthcare system to be successful, both for patients and for families. I have some questions that people have asked. And I think these questions were absolutely incredible. Thank you for sending these in. One of the first ones is, why are we talking about this? Why are we talking about end-of-life care, palliative care, and hospice care? And I'll do the definitions in just a second. We're doing this because 70% of Americans, when polled, and studies are consistent, multiple studies across the spectrum are consistent with this, 70% of Americans say they want to die at home. They want to be at home, surrounded by their family and loved ones, and comfortable. And they want to have done what they needed to do to complete the circle of life. They need to leave this world fulfilled. Let me tell you what, if I got a diagnosis today from my primary care doctor and I was told I had 60 days left to live, and while I love all of you very much and I appreciate what you do, I would never grace the doors of this institution again. My 60 days, I'd definitely tell you the first thing I would contact about 10 of my closest friends and tell them, congratulations, we're going out of the country for a little while. And we would go somewhere in a very large house and have a very great time. And Visa would get a very large bill. And so that's what I would do. I would spend time with my family. I would be going to my favorite restaurants and eating. I would watch my favorite movies. I would not be sitting in a doctor's office at all. Don't want to see them. I would not be letting you people stick me with knives and putting rubber hoses into all different orifices of my body. This is not what Americans really want. They just don't know how to talk to us, and we haven't really figured out how to talk to them. So remember, 70% of Americans want to die at home surrounded by their loved ones. 80% of Americans, however, die in the hospital. Die in the hospital. When they're not dying in the hospital, where else are they dying in the healthcare system? Very frequently in the nursing home. This is not what America wants. We are the customer service industry. Healthcare is a customer service-oriented business, and it is our responsibility to help people get what they truly want. And so we have to talk about end of life, even if it's very uncomfortable. Now, what are barriers to talking about end of life? One of the biggest barriers is that physicians are not comfortable talking about death. In fact, many of us in medical school were trained that death is failure. If you have somebody die, that you failed that person, which is completely against everything that science and nature tells us, because we're all born to die. Life is a terminal condition, and so it makes absolutely no sense to do that. But a lot of physicians got this subconscious training that if they die, you're not a good doctor, which is preposterous. Number two, many physicians are afraid of lawsuits, and most lawsuits are based around death. So we are very afraid of that. You know that physicians who are under a malpractice lawsuit have a 600% increased chance of committing suicide as compared to the baseline population? 600% higher chance. Physicians who are being sued are at high risk. It's very scary. Whenever I hear about physicians who are being sued for malpractice, it is a huge red flag for me. They need extra help to get through this. That's why, if it's that much stress, if it's enough stress to make you want to leave this world and leave your family and kill yourself, that's a lot of stress. And so physicians admitting that someone is going to die is very stressful for physicians. We're not great at talking about it, even when we think we are. When surveys and good studies have shown that physicians think that we are very good about talking about death, we believe that we're good about that. Quite frankly, we all believe we're God anyway, so why wouldn't we think we're good at that? But we're not, and families are telling us we're not good about it. It's okay to admit when you're not good at things. Let me tell you what, nephrologists, I love nephrologists because I don't like the kidney. I do not, that is just one organ that just really doesn't do it for me. I was never great with nephrology, and when I practiced in the hospital, I definitely used nephrology consults very frequently because that's not something I was good at, but I knew people who were good at it and they would take care of it. It's also like electricity in my house. I darn near electrocuted myself doing something stupid on a stove that was still plugged in and wound up shooting myself halfway across my kitchen not knowing what had happened. I don't do well with electricity either. That's why they make electricians. And so, for the healthcare system, there are doctors who are comfortable talking about the end of life, who are willing to help our colleagues work as a team. See how that word team is coming in? The entire healthcare system is doing a 180 rotation from being physician-centric, the very paternalistic style of medicine, and we are becoming much more team-based, and we'll talk about that in a minute. So we need to use the members of our team. Let's talk about finances for a little bit. Yes, I know I hate bringing business into medicine, but there is a little bit of business for it. Do you know that 65% of the Medicare expenditures last year went to take care of people in the last 6 weeks of life? We spent over half of our Medicare dollars, prescriptions, physical therapy, occupational therapy, surgery, all of that. Don't just think of the hospital, think about everybody at home, all those seniors on Medicare. And we spent 65% of our dollars in the last 6 weeks of life. Ladies and gentlemen, that is a terrible, terrible return on investment. We did not do well. We did not spend our money wisely. And why is that? Because we are utilizing the most expensive forms of health care, the highest cost of health care, and we're getting nowhere. We're not doing a good job, and it's okay. I wasn't doing a good job about taking care of myself. I was eating terrible food and I wasn't exercising. My doctor told me I was tubby. He told me it was time for me to start exercising. And he started teaching me on how to do things, and I went and found help to do it. And together, as a team, I got better. I took things that I didn't want to hear and doing things I didn't want to do, and I have actually improved myself with that. And that is our responsibility as a healthcare team. 65% of our dollars in the last 6 weeks of life. There's a lot of ways we could be saving a lot more people and shaping a lot more people's lives in a far better way if we would accept death and talk about death before it actually happens. The healthcare system is broke. There is no more money. No more money is coming. And so we have to utilize our resources and learn to utilize them appropriately. We estimate that if we could reduce 10% of the high-intensity deaths, where we have people in ICUs and we've sliced them up, we've done every test, we've scanned them from stem to stern, because we know that they're dying, but we just haven't talked about it. If we could reduce that by 10%, we could actually add about 10 more years onto Medicare. The Medicare Treasury, the pot of money for Medicare, we could actually extend it quite a while. I will tell you that Centers for Medicaid and Medicare Services are working toward this very aggressively. I attended a talk last year at the Centers for Advancement of Palliative Care from the director of CMS, and it is coming. They are looking at all sorts of things. They're even looking at regions. If you have two different groups doing the same thing in a region, they both have the same results, but one group is spending 300% more than the other one, that group that's spending 300% more is about to start getting some visits from Medicare and Medicaid. It's changing the way that things are happening. So let's talk about some of the technical terms that we use. They're confusing, and I'm sorry about that. I'm going to start off with the one I don't like the most, comfort care. I don't like the word comfort care, because if you're saying, well, we're doing comfort care for someone, that's also like saying, well, we're not doing comfort care for this person. Bed 1 gets comfort care. Bed 2, you don't get comfort care. Let me tell you what, when I'm in the hospital, I want to be comfortable the whole time. And so comfort care is just kind of a ubiquitous term. It's a term that kind of makes us feel better about ourselves. It has in the past been kind of used to display that we're trying to keep somebody comfortable at the end of life, but it's pretty nebulous. I think we should always be trying to make sure our patients are comfortable, because I can tell you that's what the patients want. I've been in a hospital with kidney stones. I definitely wanted to be comfortable. So comfort care is a term I just think needs to go by the wayside, and most major organizations agree with that. Then there's the term palliative care. What is palliative care? Initially, palliative care's definition was very strict, and it just said that is taking care of symptoms when you cannot cure a specific condition. So if my mom has some arthritis in her hand and she takes a couple of Tylenol and her pain goes away, did we cure my mother's arthritis? Of course not. Did we increase the amount of synovial fluid in the joint space? Of course not. We just made the pain go away. That's a very simplistic version of palliative care. As palliative care as a specialty has moved forward, palliative care is more about a biopsychosocial view, mind, body, and spirit view of how we are taking care of complex patients and providing quality care for them and achieving their goals. Palliative care is a very, very big umbrella, and there's different parts underneath that umbrella, and one of those parts is hospice care. People get hospice and palliative care confused, even physicians do, because those terms have been kind of used interchangeably. Palliative care is a general philosophy of medicine, and it's being used to talk about different groups, different types of clinics that are working with different patients about, especially high-risk, very complex, medically complex patients, about taking care of them in the last few years of their life. Not the last 6 months, but the last few years. Palliative care can start very early. Hospice care is much more specific. It is a branch of palliative care for people who have a life expectancy of 6 months or less, where a specific team of physicians, nurses, social workers, chaplains, home health aides, and volunteers work together to help take care of people who are dying. When you talk about hospice care, the ultimate criteria for hospice, and you will hear people talk about all sorts of stuff. I'm here to tell you the number one criteria for hospice care. Are you going to die in 6 months? And are you willing to adapt to a palliative philosophy of care? If I have someone who's got stage 4 cancer, and by God, they've got to have they've got to have this Opdivo. This Opdivo is something they have to have. Then that's looking more at an aggressive treatment plan. That is not a hospice-ready patient. Are they ready for palliative care? Absolutely. They've got stage 4 lung cancer. They are going to die. And so they're great for palliative care, but they're looking at a much more aggressive stance by using chemotherapy. So they're not quite ready for palliative care, but they can certainly transition into hospice care in the future. So hospice care defines that. Supportive care. What is supportive care? Supportive care is relatively the new name for palliative care. The National Hospice and Palliative Medicine Organization and the Centers for Advancement of Palliative Care got together, and because we initially were considered hospice care, but we did so much more, and people got afraid of the H word. It was like Darth Vader walking down the halls. So then we decided to name it palliative care. It's a much happier name. And palliative care encompasses a lot more of what we do. We do talk about hospice, but we also do palliative care. We help take care of medically complex patients that are undergoing aggressive therapy, undergoing aggressive curative treatments, but helping support them in relieving their symptoms and providing them spiritual support, psychological support, and physical comfort. But palliative care and hospice were used too much interchangeably, and so that created a lot of confusion. So then we came up with a new term, supportive medicine. And supposedly, according to major organizations, we're all going to be supportive. We're going to be supportive medicine now. I'm a proponent of this change as long as it's the last change. So supportive care describes what we do a lot better. We help support patients and support their families. We also help support our physician colleagues, supporting them in talking about the end of life, supporting them in working with them and patients to help provide the quality of care that patients are looking for when they're in the last few years of their life. Another question I had was, what is a DNR? How does DNR play into this? All DNR means is do not resuscitate. And do not resuscitate means we're not going to do cardioversion, we're not going to intubate you, we're not going to jump on you and do chest compressions. DNR means that. It does not mean throw your hands up in the air and do nothing. One of the things I used to just get so angry at when I taught at UAMS is when I had residents and fellows that would go to patients and say, well, there's nothing more that we can do for you. How heartbreaking is that? If I was a patient and I was told that the most powerful health system on earth was throwing its hands in the air and turning its back on me and saying there was nothing more that they could do for me, I would be heartbroken. I would be terrified. This is not true. We can always do more. We can always do more until someone passes away, and even after, we can still do more to help patients and families. So DNR does not mean we give up. I am a DNR. I do not want you people bringing me back. I am of the Christian faith. If I am rising up into the arms of Jesus and you put a lasso around my ankle and pull me back to this earth, you better hope I don't wake up, because I will be very cranky. I do not want to come back. And when we talk to patients, we do not tell them, and all of you in this room have seen it, all of you in Little Rock have seen it, we can create some hellacious quality of life for people when we try and cardiovert them. Think about all those anoxic brain injuries that we have, the vegetables that we create. With the best of intentions, and we always know what road that paves, but DNR, I do not want to be brought back, and a lot of people don't want to be brought back, and especially when they find out the risks that you can come back as a brain-damaged individual lying in a bed, pooping all over yourself. That is not a risk I am willing to take. So DNR means, go ahead and treat me. If I have kidney stones, please fix me. Oh gosh, please fix me. If I break my arm, yes, put Humpty Dumpty back together again. However, if I'm leaving this world, do not use our technology to torture me. I do not want this. And it's interesting because there are some great articles that recently have been published talking about why do Americans not get to die like physicians. There's a very big difference in the way that physicians die in the United States, how nurses die in the United States, and how non-medical people die in the United States. And nurses and physicians very frequently are dying much more at home, peaceful, surrounded by family, and not having their death artificially prolonged by the healthcare system. We can artificially prolong the dying process. In fact, we're brutally efficient at it. There are other ways to do this. So there's DNR. DNR means you still get good health care. Advanced directives, same thing. An advanced directive means you still get all of the care that you want. An advanced directive doesn't even become active until two physicians say, you know what, this person's dying. It's kind of hard to get doctors to do that. I did a study at UAMS before I left. I took the last 250 adults that died in the hospital, and I went through their chart. And I looked to see how many times was the word death, die, dying, or some variation of that. Not a euphemism, not crossing over Jordan or poor prognosis. I had a patient who was mad one time. The doctor said, well, you've got a poor prognosis. And I walked in shortly after that, and he said, look, I know I don't have a lot of money, but I still want good care. I said, well, of course you're getting great care. I promise you that, but I don't understand where this is coming from. He said, I have a poor prognosis. Because I'm a poor person, doesn't mean I get the same health care as this person over here. It broke my heart, and I finally explained to him, I'm sorry, poor prognosis means death, but doctors are afraid of saying the word death. And when I told him that, he said, well, I know I'm going to die. He was fine with it. It was us that had the problem. And so it's important when we talk about it to use the word death. So for an advanced directive, two doctors need to say that someone is dying. And then that advanced directive kicks in, and advanced directives can be tailored to whatever the patient wants. You do not have to have a lawyer to do them. Thank goodness. Far cheaper. And you can get real specific. I want this type of antibiotic, but I don't want that type of antibiotic. I want this done for 2 days at most, and if it doesn't work in 2 days, then stop this. Also, it gives the healthcare system the huge advantage of knowing what to do when the time, or who to ask what to do next when the time comes. I will tell you, for my advanced directive, I don't have kids, I don't have siblings, and I don't have a spouse. That means my mom and dad would be my next decision maker. I love my parents dearly. They're 71 years old. They are the most wonderful people ever, and I will never make them have that burden. I have my healthcare power of attorney signed over to one of my best friends because I do not want my parents ever having to bear that cross. I have the power to take that cross off their shoulders, and I'm doing it. And so it's important to talk to our patients about how to do advanced directives. Make sure that they choose people who are going to do what they want. If mom says, I don't want anything keeping me here, artificially prolong my life, I know that I'm dying, don't torture me, keep me comfortable and let me go, then it's a good idea not to get the child that's going to have machines created to keep her alive. If you hear, well, as soon as mom goes unconscious, I'm just going to do whatever I want. Bad choice. Turn the other direction. It's time to find someone who's going to stand up and is comfortable being the advocate for what you want. And so that's how advanced directives and DNRs. A lot of people have the misconception that advanced directive and DNR means just give up on me in the hospital. I see it every week in this hospital. And so it's our job to educate them that we're still going to give them high quality care. Something else that happens that several people asked me to talk about is the phrase, well, they're just not ready to hear about it. First question is, who's not ready? Is the patient not ready to hear about it? Is the family not ready to hear about it? Or is it the doctor who's not ready to talk about it? Why is that doctor not ready to talk about it? Are they worried that they're going to get sued? Possibly. Are they worried they're going to make people angry? Probably. Are they subconsciously worried that they won't be able to do any more types of procedures or any more interventions that make sure that their kids go to college and get it paid for? Yeah. Let's be honest about it. There is a subconscious reward system built in the healthcare system that if the more you do, the more you get paid. Well, who doesn't want to be paid more? Everybody wants to be paid more. So there is a subconscious mechanism that trains physicians. The more they do, the bigger that paycheck is when they get home. Uh-oh. So there's a lot of things that we have to think about, and we have to be honest with ourselves. A lot of doctors don't like to think about this. We don't like to go inside of ourselves and say, you know what? Could that be me? But we have to ask ourselves about that. We have to repent. Repent means to rethink. We need to rethink this every day. And healthcare has rethought itself, and it's changing, and we have got to keep up with them. So when we're not ready to hear about it, that's a very dangerous phrase. Let me give you another example of I'm not ready to hear about it. If I have a very nice lady who came into my family practice office and sat down and said, you know, I'm feeling nauseated. And I said, oh, okay. And she said, oh, God, I sure hope I'm not pregnant. You know, we're just not ready to have a baby. I sure hope I'm not pregnant. Okay. And we did all the lab work, and we did the urine test, and the urine test came back positive. And I saw that woman was pregnant. Would I sit there and say, oh, you know, she's not ready to hear about this. I'm not going to tell her she's pregnant. No, I'm not going to do that at all. Yeah, and let's say that I don't tell her that, and then she's so excited about that, she and her husband go out and have a bunch of margaritas that night. In fact, they make a week-long party of it and drink a whole bunch of margaritas. And then a couple months later, oh, maybe now she's ready, and this kid pops out with fetal alcohol syndrome. Or maybe I don't think she's ready yet, and 9 months later, she comes back to my office with a baby in her arms, looking at me with a look that could kill, with a lawyer right behind her. Let me tell you what, my malpractice insurance, there was no hope for me to win that lawsuit, and the state medical board would yank my license. It is hard and it is painful, but it is the reality that even if people are not ready to hear it, we have to tell them the truth. The principle of autonomy is the number one guiding principle of medical ethics. And patients have the right to know all about their condition from an unbiased point of view. And that even includes death. If you don't tell people that they are dying, it is unethical. So we have got to be better about practicing ethically. Yes, there is going to be some pain involved. Yes, there is going to be some crying. One of the first reactions to bad news is anger. Elizabeth Kubler-Ross wrote about this domains of grieving, 50 years ago. It hasn't changed. So yes, there is going to be an emotional blow-up. If you're not able to handle that emotional blow-up, that's okay too. I'm not good at nephrology, remember? So I go get a nephrologist. If you're not ready, if you're not able to handle that situation, have a teammate to help you. That's why we support each other. So delivering bad news can be done different ways, and you need to start working with people who are good at it and delivering it. Helping patients know the truth. Because again, if I have 60 days left to live, and my primary care doctor doesn't tell me for 30 of those days, and I find out about that, I'm going to be a very angry man, because that's 30 days that was robbed from me and my friends and my family to do what's important to me. It's just the right thing to do for patients. So not ready to hear about it is not an excuse anymore. It's gone by the wayside. Other questions. What kind of patients would make a good palliative care consult? Can't tell you about all of them because we could be here all week. But let me give you a few examples of who are good palliative care patients. Patients who have chronic, non-curable conditions. So think about it. I mean, obviously the easy ones are out there. It's not stage 4 cancer. I mean, it's amazing. Most major cancer institutions in the United States now have their own palliative care doctors or have palliative care embedded into their groups, and they're automatically starting to see stage 4 patients. There are great studies, including the Journal of Clinical Oncology, that is showing that cancer patients actually live longer with palliative care, and some studies are even showing that palliative care patients, some cancers who are in hospice are living longer than when they're getting aggressive and curative treatments. So there's some great data. University of Alabama at Birmingham is putting out some phenomenal data right now on this. And so I definitely think that understanding when we have conditions that we cannot cure. So lots of people think about cancer. Think about Alzheimer's disease. When you get diagnosed with Alzheimer's disease, you have just been diagnosed with a terminal illness. Yes, from time of diagnosis, until death is about 10 years, but it is still a terminal diagnosis. We don't know what causes it. We don't know how to cure it. We don't really have any truly effective treatments for it. That means that, unfortunately, you're going to die, unless you die from something else first. But we have to start thinking about Alzheimer's as an illness where we start talking about death up front. Let's take a look at a lot of the ones that are responsible for readmissions. COPD. Tell me the last time you saw somebody cured of COPD. You can't. You can't cure COPD. CHF. Now, there are some cases in certain conditions with congestive heart failure that you can reverse people back. Just like if you have diabetics, you can reverse them out of a non-diabetic state. However, in general, cardiovascular disease is one of the number one killers. And so congestive heart failure, it progressively gets worse. And as people progressively get worse from COPD, and they get worse from congestive heart failure, and they get worse from end-stage renal disease, and they get worse from cancers that we can't cure, they're going to become more uncomfortable. They become more uncomfortable. Their bodies become frail. They're not able to eat. They become nauseated. They have a lot of spiritual stuff that's happening. Spirituality is very important at the end of life. If you really want to see a doctor run a 26.2 marathon, mention religion. They will go flying out the door. We are not good about talking about faith and healthcare. And it's funny because our patients really want us to at least ask about it. At least ask about it. And to help find them support. I am of the Christian faith. So I always ask my patients about their faith. And then when I find people who are of other faiths, I'm not going to talk to them about their faith because I don't understand it. I mean, if I took my car into the shop and I had some guy that basically said to me, I don't know what I'm doing, I wouldn't leave my car with that person. I certainly wouldn't drive it again. And so if I don't know what I'm talking about, then I go find teammates to help me. I will call a rabbi. I will call for an imam. I will call for a monk. I will ask people to come help me with this. My patients, our patients, want us to at least ask. And ask if it's important to them. All right, this is your faith. Is this important to you? Do you want to talk about it? No, not right now. Okay, fine, we can talk about it here in just a little bit. But they want to know that we're open to talking about that. So when we have these conditions, we start, like we're talking about, I got off on a little aside there, but we're talking about these conditions, these conditions that we can't fix, that progressively get worse, that have physical symptoms, emotional symptoms, spiritual symptoms, and please, please, please do not forget the really important people, caregiver symptoms. How many times have we seen caregivers die before the person actually has a terminal illness? I have seen caregivers caregive themselves into the grave, or caregive themselves into a condition that they cannot recover from. Then they become terminal. And so we've got to think about our caregivers. That's what palliative care is good at. And so palliative care could start working with patients who have these complex, chronic, long-standing illnesses to help make them comfortable, to help identify goals, and to help tell them what the future is going to be. Remember, most patients that are stuck in the healthcare system, they've not done this before. They haven't walked this path before. It's our job to tell them, this is what's coming. This is what's going to happen next. This is what's going to happen. If they say, oh my gosh, you mean if they put a feeding tube in me, that I'm going to wind up stuck in an institution with strange people putting their hand on my private parts multiple times a day, and I won't know anything except drooling on myself? I don't want that. That's not what I want. Also think about it when we talk about this. It's how we present the question. So if I come up to you and say, hey, you want to die? Yeah, I've actually seen physicians do that. Hey, do you want to die, or do you want me to do something? Well, I mean, no, I don't want to die right now. Thanks for asking, weirdo. As compared to saying, unfortunately, there are some things that we can't cure in the American healthcare system, as much as we try, and we don't know how it happens. And so when we have a condition that keeps moving forward that we don't know how to fix, unfortunately, that does lead to death. And I know this has got to be hard for you to hear. I'm so sorry. How can I help you? that a much better way than saying, well, you want to die today? So with palliative care, we have these complex conditions. We also look at prognostication, and every specialist needs to start looking into prognostication. I can tell you on my boards, the last time when I researched, prognostication was much more prevalent in my board questions than it has ever been in the past. So we need to start looking into the future. Who is dying? What is going to happen in the future, and how do we prepare for that future? Palliative care actually does a very good job of this. Ow. I'm not ready to sign up yet. Give me just a little bit. And so what happens is we have to start looking into the future. Hospital admissions. Hospital admissions are a very important point. We know when people are having frequent hospital admissions, that is a sign that everything that we're doing, all of the best medical care that we can give, all the high power care that we can give to make somebody better ain't a-working. If we could have fixed it, we probably would have done it 3 admissions before now. So when we get into this chronic cycle, this yo-yo cycle, this in and out cycle, we know that what we're doing is not working. We're buying a little time, but things are getting worse, and so we need to start preparing for the future. We take a look at it in Arkansas. When there's any threat of snow or whatever, what happens? Everybody rushes to the grocery store, and what do we buy? Milk, bread, and eggs, which doesn't make any sense to me because, I mean, what do you people do? Just sit around the house and make French toast all day? No, I'll be over at the pizza aisle. And so we need to start preparing in that example, we do need to start preparing our patients and think about which way are we going to prepare patients in the future. Are they going to be the milk, bread, and egg kind, or do they want to be sure they got a couple of 2 liters of Coke and some really good pizzas? How do they want to spend their time? We need to start looking at projection models. Now, how long do people survive on dialysis? In fact, one of the things that palliative care is doing in other parts of the country right now is we are looking at patients before they get to dialysis, and we're saying, okay, we see these numbers. This is our projection. We know that you're going to need dialysis soon, so why don't we go ahead and get a graft done now? And so instead of waiting for someone to fall apart and putting them in the hospital for 10 days where we have to put them on dialysis, get them cleaned up as best as possible, then putting them in the operating room and putting a graft in, and then putting them back to the floor, and then putting them back on the machines to make sure the graft work, why don't we start looking to the future and say, okay, we know that you're on the point of the tipping scale. Let's go ahead and put this graft in first. So and we'll see you a little bit more often. So as soon as we've seen that lab start to turn, we're just going to get you straight to dialysis instead of a 10-day emergency hospitalization. What a fantastic idea, preparing for the future. We also started taking a look at a lot of procedures. Cardiac bypass, for instance. We know in Arkansas, and Centers for Medicare and Medicaid Services has the data, that we are bypassing a lot of people who are not going to live. There are studies that show that at certain points, medical management is far more effective than actually bypassing people. And so we know that we're doing a lot of unnecessary coronary artery bypass grafting. We haven't figured out how to approach that with the general healthcare system yet, but we know it's there. But how do we start looking at our patients and saying, you know what, you're 83 years old. There are plenty of studies that say that medical management is going to be the way to go, and that you will live longer on medical management than taking the 1 in 100 shot of having a coronary artery bypass graft and probably not surviving the procedure. As a geriatrician, I will tell you, seniors are tricky. And get those super seniors, those 80 pluses, they are the trickiest of all because their bodies have taken damage over time. Every day you stay here, you get a little more damage. And you look at these healthy 80-year-olds, and they're inspiring. I want to be one of those. I want to be like that lady on that Opdivo commercial on TV. Supposedly she's got stage 4 lung cancer, and she looks great, and she's throwing her kids in the air. I wouldn't throw a kid in the air, I'd drop it. But that old lady apparently does a great job, which when you look at it is not even a real patient, and she's not actually a senior citizen, but what have you. And so Yeah, I want to live like that too, sure. And these seniors that we see who do look like that, who do look great, their bodies have taken damage over time because that's unfortunately one of the qualities of time. It just happens. However, when you have slow damage over time, your beautiful body that God gave you has the ability to compensate. It compensates over time. And a lot of seniors, their bodies will compensate for the damage that they've taken over time, and they do really well with this until something really bad happens. You know, oh, I've got to put my finger in the plug here in the dam, make sure that one doesn't. Oh, got one over here. Okay, I got that covered. Yeah, I got this one too, and put my nose in this one. Okay, I got everything under control, and then someone comes along and pushes me, and I fall down, and now I've got 4 leaks in the dam. That's what it's like being a geriatric patient. And so when they look incredibly great, and it's so hard because I hear doctors and families all the time come to me and say, I don't know what happened. She just looks so good. And we tried this and everything fell apart. It's because we really don't understand the physiology of aging very well. And so these beautiful compensatory mechanisms, everything is wired completely different. And then when we introduce some type of trauma, and never forget, surgery is just controlled trauma. A lot of the stuff we do is traumatic. Even the medicines that we give poison to people, and we poison them, and we hope that the good cells can either repair themselves or regenerate fast enough, and that the bad cells can't. But that is a form of chemical trauma. And so we traumatize people, again, with the best of intentions, but we know what road that paves, and then they fall apart in front of us. And so we have to start looking at age groups and saying, okay, what is specific about senior citizens? What is specific about 71 to 80 versus 81 to 90? Because those are two totally different groups. And so we have to be aware of that. And that's what palliative care does. So when you see people coming in and out of the hospital frequently, they probably need a palliative care consult. When you see people who have chronic conditions that we cannot cure, that's time for a palliative care consult. It's very important to start planning ahead and planning early. I sometimes work with people who I think are going to die in 3 to 4 years. COPDers who are going to die in 3 to 4 years. But they want to die at home instead of getting here to the hospital, and they get all our high-dose oxygen and our beautiful technology. But our beautiful technology can only be used inside of the hospital. And they'll never leave the hospital again. They will never feel the sunshine on their face again, which is not what they wanted, but we just didn't tell them what was happening until it was too late. So we bear the responsibility for that as well. We just don't take accountability. Oh, hey, everybody. So the next question is talking about hospice. What kind of services, equipment, supplies, and medications are included under the hospice benefit? So we're going to talk about the hospice benefit of Medicare and Medicaid, as most major insurers follow that as well. And so hospice is to be utilized for people who are in the last 6 months of their life. Very frequently, people will transition from palliative care into hospice care when the time is right. Services provided by hospice teams. Hospice teams are led by a physician, and there may be mid-level providers working with them. There are always nurses that are working with them. The thing I like about the nursing physician team on hospice is think about when people are on hospice, they go home. Has anyone tried to call your doctor at 4:45 on a Friday afternoon? I know, that's a good joke. And so you're not getting hold of them. You're not getting hold of your doctor. It's very, very difficult. And if it's after hours, you're really in trouble. So if it's after hours, what do? Well, in the American healthcare system, we run to the big holy house of healing where everyone's wearing the nice shiny white coats. And we go to the emergency room, which is a 75% chance you're getting put into the hospital if you go to the emergency room. And so we take these sick people, and we know they're super sick. They want to be at home, but they can't get anybody to help them, so they go to the emergency room, and the emergency room puts them upstairs, which is breaking the healthcare system, and it's not what patients wanted from the get-go. They want care at home. So having physicians and having nurses who can do house calls, and these nurses who can reach physicians 24 hours a day to respond rapidly to the needs of patients in a very dynamic time, who can answer simple questions. Very frequently on hospice, we get calls from families that they just need a question answered. We answer a question on the phone, and it saves an emergency room visit to a hospitalization. That's one of the beautiful powers of hospice. Hospice also has chaplains to address the spiritual needs that we've talked about, social workers to help access social systems. I had a gentleman who was so terrified about what he was going to eat because his wife was a primary cook, and now she is terminal and she can't cook anymore. How is he going to survive? The social worker realized quickly, this guy qualifies for Meals on Wheels. We have the problem covered. So social workers are important. Volunteers are incredibly important as well, and home health aides. Now, on the hospice benefit of Medicare and Medicaid, the hospice can supply up to 10 hours a week. And that's very important to let families know. Families think the hospice is going to come in and do 24-hour-a-day, 7-day-a-week of care at home. Many of them have that expectation. No, what we can do is we can provide home health aides up to 10 hours a week, plus having nurses come out and visit. Typically on hospice teams, what you'll see is that the nurses will come out and visit more frequently at first because it's a transition period, it's a new time period. There's a lot of discombobulation, and we need that strong leadership at the very beginning of a hospice admission at home to make sure everything's good, make sure everything's stable, and then sometimes, depending on how the patient does, the nurses can kind of back off. They don't have to be there as much. On hospice, we're not trying to be intrusive, we're not trying to take over the house, but we also don't want to seem distant. And so it's about that balance. Or as I say, the best story of medicine is Goldilocks and the Three Bears. Not too hot, not too cold, just keep it just right. And so that's what a hospice team. Hospice is responsible for providing durable medical equipment. So hospital beds, Hoyer lifts, bedside table, shower chair, wheelchair, those types of things. Additionally, hospice covers hospice-related medications. Now, this is important to understand the difference on this. If I have a lady who's got stage 4 lung cancer, and she had a goiter 40 years ago, and they took her goiter out, and she's been on Synthroid since that time, hospice cannot pay for that Synthroid. That's not a hospice-related diagnosis. Her regular Medicare or Medicaid will, but hospice will pay for like the pain medication, the nausea medication, the antidepressant, the sleep medicine. They can pay for the hospice-related stuff, but if it's not hospice-related, if it's a guy who's on hospice for COPD, we can't pay for his prostate pill. That's actually, the hospice will actually get fined by Medicare for doing stuff like that. So that's what hospice provides. What does hospice cost? Hospice itself is completely covered under Medicare Part A and by Medicaid and by most major insurers nowadays. If you have a private insurer, such as Blue Cross and Blue Shield, I always encourage case managers to call the case manager at the insurance company and work with them. The Blue Crosses and Blue Shields have figured out that hospice makes their patients much happier. This is what their patients have been wanting. Much better customers understand it's a far more cost-effective care. They're making the patients happy and they're doing a better job. And so Medicare, Medicaid. Medicare and Medicaid are nice. You don't have to think at all. If it's a private insurer, you may have to think more and you may have to think outside the box, but you can actually get more done. They're kind of nice like that. So hospice is covered under Medicare and Medicaid. What is not covered is room and board charges. So if you're going to go to a nursing home, hospice cannot pay the room and board charge. If you're going to a residential hospice, Medicare does not cover the room and board fee there either. And so room and board would have to be paid by the family. Barriers to hospice. One of the biggest barriers I see, quite frankly, is money. And so what's happening is we're having patients that are so sick, and we've kept them alive so long, they're so sick, they can't go home and the family can't take care of them at home. They don't meet qualifications for inpatient hospice, so they've got to go somewhere. And where do they typically wind up going? They have to go to a nursing home. But the families can't afford to pay the nursing home for long-term care. Or if you're on Medicaid, the nursing homes want a check up front to pay for any costs that they may not recoup if the patient does not live long enough to get on Medicaid. And the families can't afford this. And so what happens is the patient winds up on skilled nursing rehab at a nursing home, which costs significantly more money than hospice does. And that is a big barrier. Medicare and Medicaid services are aware of this, and they're trying to figure out a way of how they can help take this barrier down. Other barriers is patient and family ignorance. And that's on us, all the people sitting around on a white coat, both on the TV screen and here in the room. It's because we're not talking about this, and we've got to start talking about it, and we've got to start talking about it earlier. It's interesting because when you look at the East Coast and the West Coast, where there's a lot of innovation happening in healthcare right now, the Kaisers, Herman Memorial, these major health systems, there are new things that are happening, and automatic palliative care consults are already happening. They are looking at length of stays in ICUs. If you have been here this long, you automatically get a palliative care consult as soon as you walk in the door. If you've been admitted to the hospital 3 times in the past 2 months, you automatically get a palliative care consult. If you have certain diagnoses, you automatically get a hospice consult. I actually have a friend of mine who graduated who went to work for a major oncology group, and they have 7 different cancers. If you have a stage 4 or an equivalent of a stage 4, you automatically get a palliative care consult. So we're starting to look in these types of directions, doing automatic palliative care consults. Included in that question, I had a great question said to me, is it appropriate for nurses or social workers to address hospice or palliative care with patients and families? You betcha. Yeah, that's a bad Sarah Palin. You betcha, I'm a barracuda. So, yes, it's important. Remember, this is the healthcare team. There is no I in team. And so we do function as a team. And with the new healthcare system and the new way things are changing, it is important for social workers and case managers to feel comfortable talking about palliative care and hospice care. If patients and families ask about it, it's important. I can tell you, I looked kind of younger when I first went into practice, when I got out of residency. I had a fantastic nurse. He was a great guy. He's about 15 to 17 years older than I am. And I would get done taking care of somebody, and I would leave, and he would go into the room to do the after visit. You know, here's your handouts and your medications. And very frequently, my patients would stop and say, "Okay, let me ask you a question. He said to do this, this, and this. Is that right?" It's like, "Well, he's the doctor, and I'm the nurse." Like, "Yeah, but he's too young. So what do you think?" My nurse had a great relationship with my patients, and over time, despite my youthful appearance way back then, they actually learned to trust me too. My nurse was critical for doing stuff like that. And my nurse, he heard things from families that they never told me about. It wasn't my fault. They felt comfortable talking to him. At my last clinic, where I was for 6 years, my nurse was absolutely incredible. She could get more information, and especially on the social components, out of patients than they were comfortable telling me. That was fantastic. And yes, I needed her help to make sure that we worked together as a team to get what my patients needed, what my patients wanted, because it is my job to take care of them and their needs. And so we function as a team. So if you have patients, or you have families, or you hear the floor nurses talking about this, it is important for case managers are critically important. God, y'all have jobs I would never be able to do. I admire, I'm impressed with y'all every day. I don't know if I could do it. But you do, and so you have a role in this, and we have to be aware of that. We also need to start working with physicians and making sure physicians understand that in the hospital, it is a team. Baptist is going to work on a team, just like UMS works on a team, and CHI St. Vincent works on a team. And so we've got to start getting our teams, understanding what our teams are and how they work. Look here. Explain the rules and issues if people want to revoke hospice. Okay, so hospice is not written on a stone tablet by the finger of God, and people can revocate hospice. However, anytime there's an action, we also have to take accountability and responsibility for our action. One of the things that Medicare is looking at hospice is now, if you have people who are going off of hospice, onto hospice, off of hospice, onto hospice, that is an automatic, that's a big flag saying, come audit me right now, and they are having those types of audits. In order to be on hospice, we really have to accept the hospice philosophy of care, that being at home is important, that dying at home is important, that really accomplishing the goals of the patient. If the goals of the patient are, anytime something happens, I'm going to go running back to the hospital, then hospice is not the option. Unfortunately, home health isn't a really good option either, and it's very difficult. We have to spend a lot more time and start working with these patients. You know, palliative care doctors very frequently are given time. They're paid for by hospital systems to have extra time to sit down and meet with these very complex patients. Instead of having to run in and run out because they have to see 40 people in the day, we actually have the time to sit down and have a 45-minute conversation of, what do you want? How do I help you get this? And learning the resources. I mean, I work hand in hand with the case managers every day, and I learned so much from my case managers on what types of resources are available. And so that's important to get us there. It's 2:03. You've managed to stay awake after lunch. I'm really impressed. I think that we've covered all the questions here. I'll be happy to take wrong, let me know. If a patient or a family is asking about palliative care or asking about hospice care, and they have brought it up with part of their treatment team, and we approach a physician and say, you know, this is something that this family has brought up. You know, we would like, as part of the team, we'd like to have a discussion and see how we proceed together on this. And he or she says, nope, we are not talking about that. That is, that's not the way we're going. First of all, recognize that the patients are asking a question, and the principle of autonomy is the guiding medical ethical principle. The patients have the right to know about their conditions and all options in the healthcare system in an unbiased manner. So ethically, we do have to talk to patients about that, and it's appropriate and important to do that. I think if you encounter a physician who's very uncomfortable with that, and part of that, I'm not talking about this, may be part of their discomfort manifesting that, then I definitely think that working, at least at Baptist, we're fortunate at Baptist Little Rock and Baptist North Little Rock to have supportive care teams. And I would actually call the supportive care doctors and say, hey, can you help me? I've worked with this. As my teammate, can you be a liaison and help talk to this physician about this? I think we have to do that because it is very much an ethical thing. It is an ethical standard. If that is insufficient, then we have chief medical officers, and our chief medical officers are responsible for ensuring the rights of patients throughout the entire health system. And so it may be an opportunity to open up some bridges and avenues of communication. So I would go to your physician champions first. Here, I'll be happy to take questions. I'll be happy to take any questions. I think I've got all the ones you all sent ahead of time to me. At that point, it is important. At that point, it is important to, I think, to reach out to the supportive medicine physicians and say, you know, this is something that's being brought up. We've tried to speak to the physician about it. The physician is the attending physician or one of the consultants is adamantly opposed to this. You know, can you meet with them and talk to them and find out what their barrier is so that we can work together for the patient? And it certainly may be the supportive medicine physician having to come up and say, I'm sorry, but this is an ethical principle that we have to talk about. This is just the right thing to do. It's tough, and it's scary because physicians have, some of us have some really big egos, and it's not just because we're a bunch of, I promise you, we're not a bunch of narcissists. But in medical school, if anyone understands the psychology of medical school and residency, it's really sick. It is very psychologically sick. That's why you see residents kill themselves. You see medical students kill themselves. The physician suicide rates are disturbing, but we don't talk about that. But it is critically important to understand that a lot of the defense mechanisms that are built during that time, a lot of mechanisms last with you. And so trying to find out what is the best way to understand those and talking to physicians who've been through that hell and that torture, we all have Stockholm syndrome. And so how do we work together with our colleagues to say, okay, let me help you with this. You may not be comfortable with these people over here, but maybe you're more comfortable with me, and that's okay. Yeah. I can tell you in the new healthcare system, with the new reimbursement models that are coming, palliative care is about to be everybody's new best friend. Because the government finally wised up and realized where you really get, how do you affect change is you have to dangle a carrot. You know, my mother was so funny when I was a kid. You know, the neighbor across the street was saying, you know, honey, if you don't do that, I'm going to make you go into timeout for 2 minutes. Kid looked at his mom, fine, 2 minutes, I don't care about that. Not my mother. Sister Betty would haul off and knock you halfway across the yard. There was no child abuse. It was just, you know, taking care of business. And, you know, Sister Betty beat the snot out of me for doing something like that. So my mother generated a punishment that made sure I learned never to do that again. With my mom's punishments, you learned real quickly not to make that same mistake. And so Medicare and Medicaid are now learning, one, they've tried to dangle carrots to make a reward that is making us move to try and get that reward. Ooh, carrot. But now they're also coming, I got a really big fist heading right for your face and your paycheck. Are you ready? So physicians are going to be moved forward. And those who adopt early adopters of innovation and technology will be the ones who will be successful financially and successful in practice. Yeah, when the asteroid comes flying for you, whoever evolves first to make it to the next ice age usually wins. Thus humans. What other questions? I like communication. I really do like communication, and especially when a physician has a patient in a hospital, they're under our care, and going back to legal issues, the first person who gets sued is always going to be the primary attending physician. And so as a primary attending, I definitely think it's a good idea to and you know, again, like I told you, my nurse got all sorts of information I never heard, but I needed. And my nurse and I had a great communication with each other. And so yes, if I have a patient in the hospital, maybe I rounded that morning and at 11 o'clock that CT scan came back that showed, you know, spots of cancer all over everywhere. And, you know, I did not have that information. You know, call up, hey, Dr. Sauer, CT scan of the brain, chest, abdomen, pelvis came back. It lit up everywhere like a Christmas tree. The family has said that if this was going to happen, that, you know, they've seen terrible things happen to their loved ones getting treatment before. They don't want to. The patient doesn't want to go through this. You know, they need something else. Is it okay, Dr. Sauer, if I get one of the palliative care docs to come and start helping the family? So what you did is you explained to me what's happening while I'm not there, because I can't be omnipresent. And I appreciate that. So you give me that information, and we work together as a team to help our patients and families. That's the way. I don't think there is an ethical. I don't think there's not a time limit like ethics says you must do this in 10 days or less. No, there's not a. Usually ethics is very grayish. You know, I know the world, black and white on the world is so nice. I would love it if it was black and white because I'm a very linear thinker. But really, 10% of the world's black, 10% of the world's white, and 80% of the world is gray. And that gray gives us fluidity, but it also doesn't give us a lot of direction. And so with that question, there is not a set number or a set defined amount of time. No. But I think it's important really to start looking at goal setting. Inside of that question, where I start to have questions, and I think where they may be driving this question is, what about futility? Let's think about futility. If someone is in a persistent vegetative state, are we going to artificially prolong their life or artificially prolong their death? You can look at both sides of the coin, and both are valid points. Are we artificially going to prolong their death and their life by using dialysis to do that? And that starts to call in the principle of futility. And is this worth it? And even there is an ethical principle about utilization of resources. Are we utilizing resources appropriately? Because there is only a limited pie. We don't have unlimited money. And so if I'm going to do dialysis on someone who's in a persistent vegetative state as compared to, I don't know, providing providing important prenatal care to mothers on Medicaid with who have twins and have a high risk of death, how do you pay for that? So I'm not going to address the payment because I try and keep money out of medicine as much as possible and do what's right for the patient. The principle of futility, I would have a very hard time doing that. One of the things that I have found to be successful, and it's with placement of G-tubes, feeding tubes, and a really great guy, Dean Compuris, who's a known gastroenterologist in Little Rock, he and Jim Matrailer did something one time that I was so impressed and blown away with. So there was a family, and their loved one was essentially a vegetable. And they said, well, we want a feeding tube put in this person. And Dean Compuris came in and said, you know what? I'm sorry, I cannot do this. I look at this situation. You have my deepest sympathy. I am so sorry for the situation that you're facing. I know this is rough. You know, there are other options. We can look toward palliative care. We can look at keeping someone comfortable. They said, you know, thank you, Dr. Compuris. We want the feeding tube put in. And he said, I understand what you want. Unfortunately, ethically, I'm just not able to do that because I find it to be artificially prolonging their death. And that's just something in my heart I can't do. And so I'm going to have to decline this. I will ask another gastroenterologist to come see you. So he said this is something in his heart and his soul he could not do, and physicians have the right to do that. And he was going to make sure that he found someone else to do it. And Jim Matrailer came in and looked at the whole situation and said the exact same thing. And when I was there, and said, he said, we'll work together to see if there's another gastroenterologist that would like to come talk to you about this. And it was funny because this was in the ICU, and the family came over to me after I talked to them, and they said, we had 2 doctors come in and say they wouldn't do this because they thought it was unethical. They wouldn't do this because they felt this was wrong. Wow. That's really made us think. That made us think hard, and we elected to go ahead and wind up going to hospice. So I think communication. I have a rule in life. I haven't seen this on a bumper sticker, T-shirt, or greeting card from Hallmark. So one of my biggest maxims, my personal maxim in life, is that conflict arises from unmet needs and unmet expectations due to poor communication. Conflict arises from unmet needs and unmet expectation due to poor communication. So I typically find that good communication, and that means knowing when to speak, but also knowing when not to speak, usually resolves those types of issues. All right, first of all, for everyone here in North Little Rock, thank you for being here. For Little Rock across the river, that magical river that people are terrified to cross. I do it twice a day, and I haven't exploded yet. So I really appreciate everyone being here. Certainly, North Little Rock, everyone here knows how to contact me at Little Rock. If you need to contact me, anything that I can do to help, palliative care or hospice care. You've got a fantastic team with Dr. Smith and Dr. Lehman and Dr. Erbland and Kathy McLean. But certainly feel free to reach out to me as well. Our case management department here, they know how to find me, and they're very good at it. All right, thank you.